Must appreciate that you're starting exactly on time, so that's a good beginning. I must thank Toxicon Society and Dr. Paili sir, Dr. Sarina, etc. for inviting me here, and thank you very much. It's always a pleasure to be in my hometown, Thrissur. So, the topic given for me is solutions to menopausal issues. So, at sunrise hour, let us talk about the sunset years. Menopause, as we know, occurs because of a marked reduction in the ovarian estrogen production, and this causes a low estradiol concentration in the blood, causing various menopausal symptoms, vasomotor symptoms, and the GSM, or the genitourinary syndrome of menopause. So here you can see how the estradiol levels come down and the FSH levels go up. And these are the symptoms which we know start from 40 years: vasomotor symptoms, sleep disorders, mood changes, and then menopause sets in. And then you have the urogenital atrophy and dyspareunia, which goes on from 50 years to 70 or whatever. The other problems are osteoporosis, atherosclerosis, coronary heart disease, cerebrovascular disease, etc. And of course, in the perimenopausal years, we have menstrual disorders. So the primary goal of treatment is for hot flushes. Other symptoms of perimenopause which respond to estrogen therapy are sleep disturbances, mood liabilities, and joint aches and pains. Estrogen is the most effective treatment available for the relief of hot flushes and of other menopausal symptoms as well. We all know that. So it relieves the symptoms of menopause and also improves bone health. Now let's look at the terminology, because there's a lot of terminology now. MHT is the broad term used to describe both estrogen, unopposed estrogen use, as well as for combined estrogen-progesterone for women who have an intact uterus. Earlier it was called HRT, and some used the term hormone therapy. They wanted a change of name. Unopposed estrogen therapy is sometimes referred to as ET, and EPT for estrogen-progesterone therapy. Now, types of estrogen, there are different types are available, and the potency and therefore the doses will differ. They also differ in the ability to alleviate symptoms and their way of acting. Ultimately, the choice depends on patient preference, drug availability, and the cost to the patient. Now, preferable is 17-beta estradiol when you compare with conjugated equine estrogens, which we are all used to using for many years. But 17-beta is better. Now, conjugated estrogen has a 2 to 3 times extra load on the liver, and the biological availability is dependent on that. So it has results of increased risk of blood clots, cardiovascular disease, etc. Now, valerate has slightly lower levels when you administer it, and it also has an extensive first-pass metabolism. While if you take 17-beta, it is identical to endogenous human estradiol and has minimum liver load, and it's much less risk of VTE compared to the conjugated. Now, treatment of hot flashes requires systemic therapy, and if it's only for genitourinary syndrome, then you can use vaginal treatment. Many forms are available: oral, transdermal, topical gels and lotions, and vaginal ring or a subcutaneous implant, which many times is placed in the body at the time of a TAHBSO. Now, oral estrogens are best avoided in conditions where there is hypertriglyceridemia, active gallbladder disease, and known thrombophilias like factor V laden. We think it's not there, but recently I had a patient who had factor V in the family, and so these patients we need to avoid. Migraines with aura. There's also probably oral is avoided. However, we have to remember baseline risk of both VTE and stroke is very low in healthy, young postmenopausal women, whereby which we mean about 5 years, say 45 to 55. Now, the lipid profile changes with oral estrogen is most favorable on lipids in the form of that HDL is increased and reduced LDL. However, triglycerides increase. Also, it has effects on SHBG and so reduces free testosterone and increases thyroid binding globulin, so lowers availability of T4, which means we have to recheck the levels and adjust the dosage. The one size fits all is out. And the current approach is to start with lower doses, titrate up till relief of symptoms is obtained. So oral estradiol can be given at 0.5 milligram, that is the lowest dose, and transdermal at 0.025, that is about 20 times less if you use transdermal preparations. And the transdermal lowest dose available is 0.014 mg, not available here, but that is the lowest dose that can be used in some cases, at least to start with. And it is also approved for prevention of bone loss, and 50% have good relief from hot flushes. So lower doses are also associated with less vaginal bleeding and breast tenderness, and the least effect on coagulation and inflammatory markers and VTE. Now, when we use a standard dose of 17-beta estradiol, oral 1 milligram or transdermal 0.05 milligram, then and also in younger women with BSO or primary ovarian insufficiency, they require high doses. So the standard dose is 1, so we may have to go to 2 milligrams in the younger women or 0.1 milligram of transdermal. And this is done for the first 2 to 3 years after surgery, after which you can taper it. Now, oral conjugated estrogens was 0.625 and in the past, and that was tested in WHI, but is used less often now. So we talked about estrogens. What about progestogens? In women with intact uterus, we all know we need to prevent endometrial hyperplasia, and it can occur just 6 months of usage of unopposed estrogen. So women who have had hysterectomy, however, should not receive progestogen because there is no other health benefit of giving progestogen other than endometrial protection. So this is important. So we need not give in women who have uterus removed, but we need to give it anybody with a uterus, even if you've done endometrial ablation, because there may be pockets where endometrium is there. So even in them, they need progestogen. Now we look at the dosage and frequency of using progestogens. You know all this, continuous estrogens like in the OCP, continuous sequential and continuous combined can be used, and this can be oral or transdermal. Now the dosage of progesterone is a cyclical regimen. First choice is always now oral natural micronized progesterone, 200 milligrams per day for at least 12 days in the month. It is given at night as some metabolites cause sleepiness. Women taking very low dose, that is 0.14, then they require very little progestogen, like just a 12-day course every 6 months. 6 months or to 12 months once they can have it. Medroxyprogesterone acetate was studied extensively in the WHI. While it is endometrial protective, it is associated with excess risk of coronary heart disease and also breast cancers. This was seen in WHI, and regimens using continuous cycles were at higher risk of breast cancer. Tibolone is another drug which came in at that time, a synthetic steroid whose metabolites have estrogenic, androgenic, and progestogenic activity. Widely used in Europe, not available in the US. We have it in India. Reduces vasomotor symptoms, but not as much as with plain estrogens. It has beneficial effect on bone mineral density and a moderate effect on sexual dysfunction, and increases the risk in women with a personal history of breast cancer. So women with breast cancer, we should not be using. So there is no increase. Excess risk of stroke was seen with tibolone. So there was a LIFT study which was stopped early, but there was no increase in mammographic density and no excess risk of breast cancer. However, the caution is, in a woman who's had breast cancer, recurrence can occur. So we need to keep that in mind. Vaginal bleeding is less, and there is no increased risk of endometrial hyperplasia. So the standard dosage of estrogen are used, then monthly progestrogens are required. Some people use quarterly progestrogens once in 3 months, which may not be adequately protective if you are using the higher levels of estrogen. If very low dosage of estrogen, we already mentioned what to do. These are the various progestrogens which you can use: dydrogesterone, drospirenone, cyprotron acetate, hydroxyprogesterone, and norethistérone. And the effects, you can see some have mineralocorticoid, anti-mineralocorticoid effect, which is useful to prevent weight gain. Now, what are the side effects of progestrogens and how do we manage? Breast soreness can be reduced by lowering the dose of progestrogens. Mood symptoms and the bloated feeling can be relieved by changing to continuous regimens. So this usually relieves the bloating. Now, alternatives to cyclic and continuous progesterone, when it cannot be tolerated, one can use vaginal progestrogens, micronized natural progestogen, or an IUD. Now, another one is conjugated estrogen with basidoxifene, which is a SERM, in which case you don't need another progestogen. Increased risk of VTE is there with this, as with any SERM. So who should I start on menopausal hormone therapy? Now, benefits far outweigh the risks below the age of 50 years. In the age group 50 to 60 years, the benefits outweigh the risks again, but after 60 years, the risk equals or outweighs the benefits. So one has to think individually and decide. Family history and things should be looked after. This again shows the same thing. Now, clinical indications, before we start, patient's age is important, severity of the symptoms, and we have to calculate her risks for one, cardiovascular and breast cancers. Attributable risks and benefit ratios are calculated before we start. Now, the age of the patient is a safe option for healthy symptomatic women who are within 10 years of menopause and under the age of 60 and do not have a contraindication. And you need to reassure her that the risk of complication is low in this group when it is taken only for 5 years. The American Geriatric Society recommends that it should be avoided after 65 years because of excess cardiovascular risk. So in the age group between 50 and 60, for a period of 5 years, it seems to be quite safe. Now, the severity of the symptoms should, like vasomotor symptoms, is there in many, but it is mild in many and they do not need it. Moderate and severe symptoms associated with sleeplessness and a negative impact on the quality of life, ability to function at home or at work, then these women need help with MHT, and we should not deny them that because of the WHI. So some really do suffer. We have to identify them and help them out, of course monitor them. Now, other indications are mood lability and depression. MHT alone or along with SSRIs can be used in these women. A lot of women have problems at this point of depression, etc. And it's a very difficult period of their life, children getting married, husbands getting retired. So lots of things are there. So we can help them if they do have problem. Sleep disturbances, when associated with hot flushes or coexisting anxiety and depression, these are the reasons when you will use SSRIs. But we must also remember there are other primary sleep disorders like restless leg syndrome, obstructive sleep apnea, which should be identified and not attributed to the menopausal syndrome. Joint aches and pains, there is some evidence that relief may be obtained. Now, the genitourinary symptoms of menopause, if that is the only thing, then you can use low-dose vaginal therapy, which is very useful for them. And it may be added to systemic therapy if need be. So you're giving systemic, yet she says, I have these symptoms. Then you can add a low-dose vaginal therapy as well. And it can be continued after you stop the systemic therapy. For some reason, if you've stopped it or she has stopped it, then she may continue the vaginal usage. Now, perimenopausal mood disorders may be associated, as I said, and it must be sought for. Sometimes they may not come out with it, and we need to screen this population for depression. Risk of new onset depression also can be there. So meditation and yoga are other options for these women. But if more significant symptoms, then you have to use SSRIs. And only then they get relief of their mood and vasomotor symptoms. So although estrogen improves mood symptoms, it does not do so in the perimenopausal women. It does not do so in the postmenopausal. So start treatment of the most severe symptom first. If it's for depression, start that first, and then add on hormone therapy. Or if it's hot flushes, start off estrogen first, and then you can see if that improves it. If not, start SSRI along with it. Now, the obsolete indications, which are no longer recommended, we have to remember, is for prevention of chronic conditions like coronary heart disease and for the prevention of osteoporosis. So earlier it was used as preventive. Now that is no more recognized, and for cognitive function and dementia. Now, contraindications are history of breast cancer, previous VTE or stroke, acute liver or gallbladder disease, and unexplained vaginal bleeding which has not been investigated and found to be normal. In those cases, we should not use. And they have a higher risk of endometrial cancer or TIA. In these cases, we do not use. Now, women with migraines, with or without aura, need not be considered as a contraindication. So you can use MHT in them. Continuous therapy is probably better to avoid triggering estrogen withdrawal headaches. Now, calculating risks before starting is important. And if you have a moderate risk of cardiovascular disease, 5 to 10% of 10-year risk, then transdermal is used, not oral. For women with uterus, using micronized natural progesterone is better than synthetic in these women. Now, if there is a high risk, more than 10%, then, or a moderate risk of 1 to 5% in 5-year risk, then, and for breast cancer, then you can suggest non-hormonal therapies and other measures. Yeah, I'm finishing, last slide. So herbal remedies, we don't know the effectiveness. Many items are there which has been tried over the years. It's up to them. Now, activities such as yoga, mindfulness, relaxation, etc. are not shown to be meaningful treatments in vasomotor symptoms. But it is good for their health, and they can definitely use that. Now, the other non-hormonal options with evidence to support efficacy are SSRI and serotonin SNRIs, also, which are effective in some but not all. Paroxetine 7.5 milligram has approval in the US for vasomotor symptoms. Fezolinetant is a new drug which has got approval in May of this year. Neurokinin 3B receptor antagonist, which acts centrally 45 milligrams per day, has been approved recently and is a big thing. Hopefully it will be a big thing for women. Now, low dose oxybutynin is effective. Standard low dose or an extended release preparation can be used. Probably less effective options include clonidine and gabapentin, and we all know the side effects of gabapentin, which is giddiness and sleepiness, etc. are there. So we have to keep all this in mind. So to conclude, after WHI, the use of HRT reduced by 80%. Now only 3 to 4% of perimenopausal women get it, as opposed to 25% before the WHI. So better knowledge is required, as many are not sure how to use it in really indicated cases. So in indicated cases, we should not deny the woman. And we have to, who have symptoms, and we have to take all their health considerations and then decide what is best for them. I thank you for a patient listening.
Thank you, Rekha ma'am, for that overview. And we all understand that menopause as such is gaining more and more importance. And we now know that there's one classification, straw plus 10 classification, where the women are classified from late reproductive to menopause and postmenopause, and each phase has got its own challenges which has to be addressed. And just I wanted one question, ma'am, that you said after THBSO you can fix in the transdermal patch and send the patient home. Do you practice that?
Well, it's not available here. Otherwise, depot preparation is there, where you put into the incision in the subcutaneous, and that lasts the patient for about 3 months. But we do not have it here.
Okay, will it not affect the post-operative phase where
No,
there
nothing.
can be chances for embolism, angane?
No.
Estrogens?
No, it doesn't, yeah. It slowly gets absorbed over the next couple of months. There is no problem. It was, I mean, I've used it regularly when I was in UK, but we came here, it wasn't available.
Okay, thank you, ma'am. I think we can go on to the next speaker, or any questions from the audience?
There is already one question, madam.
Yes.
Why prevention of osteoporosis is no longer an indication for MHT?
Yeah, because the reason why is all those things, the benefits outweigh the risks in most of these people. And we use it sort of indiscriminately. Everybody thinks, okay, it's a thing for osteoporosis, and it has not been proven to be that effective. It does make a difference, but we have to consider a lot of the other issues surrounding it. So it's no longer given for those issues anymore. Otherwise, it was just like a placebo. Everybody used to take it, okay, like a vitamin. So that's why it's no longer indicated to give for prevention. If they have a family history, their own mother having something like that, you can individualize and use it for these people.
And moreover, prevention of osteoporosis should start at the age of 30, not at menopause. So that is another.
Yeah, so it's a long period of time that they have to use, and also after you stop it, again the risk of osteoporosis builds up. So after 5 years of stopping it, it's sort of again your risk is just the same. So while you're on it, it's good.
Thank you, madam. That was a really wonderful talk.
Thank you.
Rest of the questions we'll be taking up